organized by the South Dakota American College of Physicians. I'm Eric Larson. I'm the chair of the Department of Internal Medicine and a general internist in Sioux Falls, and also the vice governor of the South Dakota ACP. The American College of Physicians is a specialty organization for internists, which supports us with education, as well as doing a lot of work in public policy. We'd love for the students to become members of the American College of Physicians. It's free for you, and Chris has put that link up in the chat. The benefits include the potential for going to meetings, poster presentations, both locally and nationally, as well as a subscription to the Annals of Internal Medicine, which is really a great journal for you guys to be looking at. There's also lots of free educational material online that you would have access to with this. And I'd like to introduce Dr. Kelly Evans, who is our moderator for the evening. She's a general internist in Brookings. She's also the clerkship director for internal medicine at the School of Medicine, and she's the chair of health and public policy for the South Dakota American College of Physicians. So Kelly, you can go ahead and take it from there.
Thanks, Dr. Larson. Glad to see a lot of students on, and thanks in advance to our panelists who are on. What I would really like to share with students, you may be at various stages of thinking about career planning. The really great thing about internal medicine is the variety of career choices that you have once you enter that field, and I hope that you'll get a taste for that tonight. I'll start by introducing myself and a little bit about what I do as a general outpatient internist. Then we'll allow each of our panelists to spend 5+ minutes talking about their training, their day-to-day workflow, their work-life balance, and just various aspects about their specialty. And once we're through everybody, then we'll open it up for question and answer, okay? So I work in Brookings, which is a smaller community. I do mostly outpatient general internal medicine. I've been back since 2016. I actually graduated from the Stanford School of Medicine in 2012, so not too far removed from where you all are right now. So outpatient internal medicine is primary care. It looks a little like family medicine in the day-to-day flow, but my patient population is much older and more complex, especially in a smaller town. I see mostly Medicare age patients in my clinic. My training leading up to this was 3 years of internal medicine. So every panelist on will have done a 3-year internal medicine residency. I went to University of Colorado in Denver for that. And then I did an extra year as a chief resident, in which I did administrative and teaching duties there. I did a primary care track in residency, which is unique. There are a lot of more programs having primary care tracks around the country just over the last 10 years, in which you get a little bit more focused primary care training, but still a very broad base in internal medicine, spent a lot of time in the hospital and in the ICU, et cetera. So my day-to-day, I spend about 75% of my work time doing primary care work. So everything from working in our respiratory clinic right now, which we all are taking our turn back there in our smaller community, doing a lot of chronic disease management, and being kind of the first person to see my patients as they come in with a new complaint, which I really like. I also do, in a smaller community, we still do some hospital calls. So we do a little bit of inpatient medicine. There are some even smaller communities than Brookings in which you'll see people doing more of a traditional practice in which they do more hospital work. I do nursing home rounds. So once a month, I go to the nursing home and round on my nursing home patients. One thing I really love about my role in a smaller community is that I get to do a lot of what I call extra stuff. And that's part because I say yes to a lot of things. But as Dr. Larson said, I'm the clerkship director at the medical school. So I spend a day a week doing that. I am the chair of health and public policy for our ACP chapter. So I go to Washington every year when there's not COVID to worry about, and work on various state policy things. I'm our medical director for home health and hospice in Brookings. So I meet weekly with our multidisciplinary hospice team. I'm on the State Medical Association Policy Council. I'm a co-host for On Call with the Prairie Doc. So once a month, I'm hosting the TV show, doing a radio show and writing an essay for that. So a lot of really broad things that are open to me as a general internist. I love that I have a lot of continuity with my patients. I love that I am the person that they know best and can guide them through their various health crises. I like being the first one to evaluate a new problem. So if my patient comes down with their first symptom of cancer, for example, usually I'm the person that investigates it first and does the workup even before we refer on to subspecialties. And it's just a really good mix and variety. So I really love what I do. I think what we'll do is continue to go through the panel, and if everyone else could share their training, what their day-to-day life is like, and any things that you really love or unique things about your job within internal medicine. We'll go to Dr. Nate Miller, who is our hospitalist on the panel next.
Thank you, Dr. Evans. Well, welcome everyone. So Dr. Nate Miller, I'm a hospitalist, and I've been a hospitalist currently in my 10th year right now. I too finished medical school at the University of South Dakota Sanford School of Medicine in 2008. So I'm a little more dated than Dr. Evans is. So hospitalist, full-time hospitalist, will do about 14 shifts a month. They say if you've seen one hospitalist program, you've seen one hospitalist program. That really is true. Classic, I guess, schedule for hospitalist medicine is 7 on, 7 off. Where I work, we have more of a hybrid schedule, but full-time is 14 shifts a month, and they're 12-hour shifts. I did my residency in Sioux Falls. I did 3 years at the School of Medicine, internal medicine residency. 90% of hospitalists are internal medicine trained. There are remaining who see adults only are family medicine trained predominantly, about 10%. And most of those have gone on to do a fellowship. So predominantly, if you're interested in hospitalist medicine, the quickest route is doing a general internal medicine residency. Similar to Dr. Evans, I actually did a chief year for my 4th year, and I think it may have even been Dr. Evans-Hullinger's last year when I did my chief year, because I like teaching, and I wanted to get a little bit more education in the academic area. I picked hospital medicine because I like a lot of things, but I also like the inpatient setting more so. I look at it as you need every patient needs a quarterback, and Dr. Larson, Dr. Evans are those quarterbacks and captains outside the hospital. And then I look as the hospitalist, we're that captain inside. Doesn't mean anyone's more important, but really we coordinate it, the care, whether it's us on or more often us along with 3 or 4 different subspecialists. So we see a high level acuity illness. Most hospitalists rotate in all different areas in the hospital outside of OB. We consult predominantly on general surgical patients. The hospital I work at, we admit about 80% of the patients to our hospital. A large majority of us do ICU care across the nation, and similar in Sioux Falls, where I work, we have hospitalists embedded in the ICU working with critical care physicians. Things that I like about my job is the variety. I also like being able to triage my patients based on their acuity of illness. Now, that's one thing you can say maybe you dislike too. If you don't like not having a structured setting, hospitalist medicine is not the way to go. And you can probably argue medicine in general probably isn't the way to go. But so additionally, a lot of hospitalists have leadership roles. So I have an interest in quality improvement along with teaching residents and leadership in medicine. So I'm the clinical vice president of our hospitalist service line, which essentially helps coordinate the hospice service across the Vera footprint and really helping drive quality projects, connecting patients or connecting physician leaders in their facilities to the people who can help that project carry through. This last year, we've been more involved in COVID, understandably. So we're involved in surge planning, all those things. We do round on the COVID units right now in the inpatient setting. And I also like to teach, so I'm a core faculty member of the IM residency, and I work with teaching service. That is all for now.
Thanks, Dr. Miller. We'll go next to Dr. Jennifer Hsu, our infectious disease specialist.
Hi, thanks for inviting me. It's fun to put names and faces together. I've seen lots of your names on paper. So I am not a USD grad. I graduated medical school from the University of Missouri and went to University of Wisconsin in Madison for general internal medicine residency and infectious disease. I pretty much knew when I got out of medical school that I wanted to go into ID. And so I think when I was deciding how I wanted to get to ID, it was a decision of, did I want to do peds or did I want to do adults? I really love my older patients. And so that's what drew me to internal medicine. Really enjoyed my internal medicine experience. I like the breadth of what we got to do in training, and probably, you know, similarly to what Dr. Evans and Dr. Miller had said, is that's actually what I enjoy about my job. Is even though I'm a subspecialist, I love that I get to cover so many different areas. I may round on an OB patient, followed by somebody on oncology with a neutropenic fever, followed by one of my HIV patients in clinic. And so I really enjoy the diversity of what I get to do in a day. I have a general ID practice. And so that means I do a little bit of everything. And even within the subspecialties, you'll find that there are opportunities to subspecialize further. There are people that go into infectious disease that do all microbiology, that do all antibiotic stewardship, that do all HIV. A lot of opportunities for even subspecialization, but I have a general ID practice, so I do a little bit of everything. And it's split pretty evenly between inpatient and outpatient care. So my group, like Dr. Miller said, it depends what group you're talking about. Across the country, there's all kinds of different models for how ID care is provided. My group functions on a hospitalist model. So we rotate in and out of the hospital. So I'll spend a 2-week chunk of time in the hospital, and then I'll spend a period of time doing clinic. And as some of you know, I'm the Pillar 2 director and the Assistant Dean of Medical Student Education. So I'm part-time. In my clinical role, I'm a 0.4 FTE clinician and then 0.7 in my role at the medical school. So lots of flexibility in ID, and I think that was one thing that attracted me to it, is that I knew there were a lot of different career paths, and then as my interests evolved, there were lots of opportunities in different areas. Couple of things I would point. So my training background, I should have said this earlier, ID fellowship can be 2 or 3 years. So as we said earlier, everybody does a 3-year internal medicine residency. I had the opportunity to do a lot of ID while I was a resident. I did 2 years of ID continuity clinic when I was a resident, but also took advantage of just getting a broad base of internal medicine. And then in fellowship, ID fellowships are required to be 2 years. It's a year of clinical and a year of research and lab work. And then if a program tacks on a 3rd year, it's usually a 3rd year of research. So that's how long it takes to get through ID in a typical program. I love the split of my job. You know, we mentioned some of the administrative roles people have. I'm the director of antibiotic stewardship for the Sanford-Sioux Falls region. So that's a piece of my clinical role. So we get to work with the pharmacist. I think one thing about ID that, again, really spoke to me was the interdisciplinary nature of it. I have a lot of contact with the microbiology lab, with pathology. We work very closely with our ID pharmacists, and I enjoy that aspect of my work. And then I'll just point out one thing that may be a little surprising that I don't know that everybody thinks about when you're thinking about a subspecialty, but I actually have a lot of continuity with my patients, surprising amount of continuity. And I think I didn't even appreciate how much when I was in fellowship. You know, I have probably a panel of about 40 or so patients with HIV infection that I think see me as their primary HIV provider. I do provide some primary care for those patients when it's on the uncomplicated side of things. I'm readily referring them back to a general internist when it gets more complicated. But I actually have a panel of patients that I follow for HIV, for chronic mycobacterial pulmonary infections, things like that, that I see on a regular basis. And so I enjoy that aspect of my job as well. So I'll leave it at that.
Great, thank you. I know we have Dr. Brandon Allard on, our endocrinologist.
Hi there. Everyone can see me? Yeah, I'm an endocrinologist at Sanford. My beginnings were in the University of Minnesota, so I did medical school there, and then I did my residency at Abbott Northwestern in internal medicine. And then I took a detour, which I know Eric did as well, but I started in cardiology after internal medicine residency, and got about 6 months in and felt like I was falling off a cliff, kind of headed into a career that I wouldn't be happy with, and then I redirected into endocrine. And so I did my fellowship at the Mayo Clinic. Endocrine is like Jennifer was describing, we are a specialty, but we also have continuity of care, which I think I have really grown to appreciate. I think it's part of what sustains me in my job as I'm 16 years into my practice now. And it's actually the people part that I find, you can only be interested so many times in a month when you've done everything and seen everything. But you can always be interested in the people in front of you. And it's what makes my day, talking to farmers about their farms, and just it's kind of what I thrive off of, I guess. The medical part is interesting. As endocrinologists, we live in a world that I think is a little bit murky, maybe to most general practice doctors. The world of adrenal function, even things that are common like diabetes, I think it can be hard to manage. And so it's kind of fun for me. I enjoy having a specialty area where I'm almost entirely comfortable almost all of the time, but uncomfortable just enough to drive me to the books and stay on my game. So we have a practice where we're about 75% outpatient, 25% inpatient. So we have one, in fact, Dr. Fenner, I'm filling in for Dr. Fenner, who is getting pulverized in the hospital. He suffers beautifully. If any of you ever work with him, it's fun to watch him work hard and suffer, but it's nice to have the balance. I would say in my specialty area, if people are looking at endocrine, 90% of endocrine physicians don't go to hospitals. So endocrine usually is an outpatient specialty. I would say it's one of the specialty tracks when people get into internal medicine. I will say I picked internal medicine almost as a default. I knew I wasn't a surgeon. I think that's kind of the first decision that most people make. Am I a surgeon or not? And if you don't know, you're not. So you're either not or you are. And from there, I wasn't prepared to commit to primary care, though I really respected family practice, thought about family practice, but ultimately just couldn't commit. So internal medicine leaves a lot of gateways open, and thought about being a general internist, obviously misfired with cardiology, and have appreciated the ability to move within, internal medicine it's like the hub on a spoke, on a wheel, and you can go down different spokes. Not that it's easy to redirect, but it's possible to redirect, which has been something I've appreciated. So I like the mix in my practice. Diversity is important for me. I'm not a proceduralist, so I do thyroid biopsies, and I don't even enjoy that much. It's okay, but it's an easy little procedure. But mostly I like clinical medicine. I like solving problems, and I like the continuity of practice. So good lifestyle overall. Because of our hospital practice, I would say our particular group has we have a more rigorous lifestyle, I would say, than most endocrinologists, but certainly my friends that do outpatient only have a very tame lifestyle. But we like the hospital too, because it keeps a different set of skills fresh. Seeing someone dying with diabetic ketoacidosis and being right in the ICU keeps me, I think, close to my internal medicine training. I don't pretend to know what the hospitalists know about hospital medicine, but you're in the game, you're in there with them, and it's kind of an exciting place to be. So call is rough. The hospital generates phone calls and sometimes sleepless nights, but I still value it as part of my practice. So endocrine is a great specialty. It's a specialty where you're going to be in demand wherever you go. Just to give a little bit of a sales pitch for a kind of an orphan specialty that not many people choose. You can point at a map. If you have a map of the United States and you want to live and work someplace that's over 20,000 people, just point to it and there's a job waiting for you, which is kind of a nice thing. So overall, fun specialty. It's collegial. We cross-link with hospitalists all day long, with cardiology, podiatry. So it's been a satisfying career. 15 years in, never looked back since I left my cards fellowship. I haven't had a moment's regret over that. And yet my friends that were in cards training love their jobs too. So I'm not trying to disparage that specialty. It just wasn't right for me. So that's me.
Thanks, Dr. Allard. Chris, I didn't see if any of our other attendings got on. Did I miss anyone?
I did reach out to them, so
Okay.
hopefully they'll pop in.
If anyone trickles in, we'll go to those other subspecialists. I would just, to round out the conversation about specialty training, if you're early, you may not be as familiar with what all is within the scope of internal medicine. So we have myself, who's mostly outpatient, Dr. Larson, mostly outpatient, Dr. Miller, who does all inpatient hospital work. And then among the subspecialties that are in your grasp, if you go into internal medicine training, include infectious disease and endocrinology. They also include cardiology, gastroenterology, hematology, oncology, pulmonary and critical care, nephrology, geriatrics. Anything that I've missed? Did I hit all I have some people in my residency who went on to do adolescent medicine from internal medicine as well. But so all of those medical subspecialties, and I would say, I would echo, you heard Dr. Allard say sort of how a lot of people sort of come to those initial stages about career choice, about am I someone who is a surgeon or not? And I would echo that. Some aspects of internal medicine are highly what I call cognitive. I feel like what I do is highly cognitive. Endocrinology is on that far spectrum of highly cognitive. Infectious disease would probably be included under that. And then there are some internal medicine subspecialties which are actually highly procedural, probably gastroenterology and cardiology being the most so. So there's a wide spectrum even on that range of things within internal medicine. We would love to answer any questions, and so we'll, as opposed to using the chat function, we'll ask you guys to use the hand raise function so that you can ask. And I would just say, if it's directed towards everyone, that's fine. We can go through the panel and have everyone answer your question. But if it's directed at a single or a couple panelists, please just state that. So we will watch for that hand raise function and get all of your questions answered. A little talk just about lifestyle, and that's something that I think people think about when they're thinking about subspecialties. And there's really a place for a wide spectrum of sort of Monday through Friday office hour lifestyles within internal medicine versus like what Dr. Miller does, which is more of a sort of shift work. You're doing more weekends and nights and that kind of thing. And even within different specialties, you'll find a mix of that. So it's a little bit hard to speak for an entire specialty when you're talking about lifestyle. I would say that you are likely to have a little more control over that than you might feel like, you go through medical school and residency, and that's a period of your life where you don't have a lot of control over your lifestyle at a lot of times. And one day you will have some control given the job that you choose and what you choose to do with that. Chris has put the link for ACP student membership in the chat. So if you're not already an ACP member, it's pretty easy to sign up and get that free membership and all of the perks that go along with it too. So just one more plug for that. What questions do we have?
I have a question for Dr. Miller. Dr. Miller, can you describe you said you work in more of a hybrid situation. Can you describe what does that kind of look like for you as a hospitalist?
Excellent question. So the initial schedule for hospitalists when the career was created was 7 on, 7 off. We have what's called a hybrid schedule where our rounding days, we can be anywhere from 5 to 10 days, even longer if you want to. We try to keep it at least 5 days so that we at least don't break up that continuity with the patient while we're in the hospital. In addition, with nights, we never do more than 3 nights in a row unless we want to. We're fortunate that we have nocturnists, similar to most programs, hospice programs across the nation that prefer nights. So for me, so full-time hospitalist with the nocturnist program, just where we work, does probably about, if they're okay with doing nights, they do about 15 to 20 a year, probably. So regarding the hybrid schedule, so even with the hybrid schedule, full-time hospitalist generally is 14 shifts a month. So it's a combination of 5 and then maybe 7 and then 2. And so there's a lot of ability to trade with your colleagues within reason in that schedule, as opposed to 7 on, 7 off. In addition with that, I am actually, I'm 0.7. As my wife says, I'm not even a full-time FTE. I'm 0.25 admin, so I'm technically 0.95, I guess. And that was in part for the weekends, so that we'd have a little bit less weekends. So that's kind of what the hybrid schedule is. Still 12-hour shifts, although we do have an opportunity to go home if we're done with our clinical at work, as long as we're available by phone call with the knowledge that we need to go back in. So.
Hey everyone, I was just wondering if you guys could each talk about how the COVID pandemic has affected each of your subspecialties differently, because I'm sure that that's been quite different for all of you. And then also for Dr. Shu, I was wondering, I had recently heard that infectious disease physicians have some on-call time, and I guess I was wondering if that was true, or if you could go into that a little bit for us.
We can maybe just go through in the order that we went. So COVID obviously has been disruptive in a lot of ways for practice. So in primary care around the country, our normal working models came to a little bit of a standstill in most places, probably not in all places. But our clinic shut down normal operations to some degree for those couple months in the spring and April and May. Trying to prepare and trying to make sure that we weren't putting patients at risk when we didn't really feel like we knew what we were doing. We moved to doing a lot more telemedicine. Again, in a small town, though I'm not a subspecialist, I'm not a hospitalist, and I'm not an infectious disease or a critical care physician. In a place like Brookings, I'm one of the people that was called on to be part of our surge planning committee and sort of our COVID planning multidisciplinary committee. So lots of meetings and trying to make sure that we were prepared if worse came to worse and we were having to keep people that were sicker than we are typically treating in a smaller hospital. I would say the summer months, then when we sort of open back up to normal scheduling, we're very busy because all of the patients that I'm used to seeing for chronic disease management that had been canceled for 2 months, on top of the people that also just were due to be seen, were kind of smashed into a few months there. And now we've kind of settled into normal practice or a normal pace. Our clinic has chosen, we have a model in which our family docs and internists always do a day of urgent care about every 2 weeks. And so now that means we're doing our respiratory clinic and we're having to staff that up a little bit. So there are days that I spend in PPE when we're sort of triaging people that are symptomatic out. And then our call is busier right now than it probably ever has been. So I was on call on Thursday night and we're caring for some sicker people than we typically would keep in a smaller town, just because of the volume and burden that our region is having right now. So a lot has changed in our practice, but we're trying to still do the important things that we need to do for our chronic patients too. Dr. Miller?
Sure. So it's really been, COVID for us has really been a tale of 2 different seasons. We had the first, I guess, initial bump, we'll call it, in April, May in Sioux Falls. And our numbers actually as a whole went down. in the hospital because not as many people were coming to the hospital, largely because not as many people were having surgeries, not as many people were going to see their clinic doctor. And unfortunately, that meant things got pushed back. And then Dr. Evans-Hullinger and Dr. Larson dealt with the ramifications of that when they opened back up, as I'm sure did Dr. Shu and everyone else on the phone, and Dr. Allard. So whereas now, we're at a state where we're seeing more COVID patients, but also seeing our usual high acuity medical patient. Regarding workflow, the one main difference obviously is we have COVID specific units that we rotate on. All of us have the potential to rotate on those. So that is a difference. So you see only COVID patients for that period of time. And usually that's 7 days in a row at the max. In addition, for me, it's meant similar to Dr. Evans, a lot more meetings. So I'm involved with our surge planning as well, and also work with a group of subspecialists, and we try to provide updates from just focusing on the clinical aspects of care of the COVID patient. We just had one about 3 hours ago on a specific patient population focused on OB-GYN and critical care. So along with some of the research that's being performed. And we're seeing a higher acuity of illness. So hospitalists, which is similar in most facilities, they a lot of times oversee the rapid response and code blue teams. We've been seeing more of those recently, and just the acuity of illness in the hospital is definitely greater than it has been historically.
Yeah, so I think from infectious disease, it really depends on the group. There are some facilities in which the infectious disease physicians are seeing every COVID patient. We have not taken that approach. As I understand, some of our colleagues in town at Avera, that has been their approach. They are seeing the bulk of the COVID patients. My group, so just like everyone else, our workflows were upended. We really were involved in policy development, guideline writing, procedural issues, surge planning, that kind of thing at the beginning. And so our clinic volumes dropped off, but our meeting volume ramped up dramatically. And so I think we were used more for the information side of things than we were the direct patient care to start with. I'll echo what Dr. Miller said. The acuity of the patients we have seen in the past 6 months is amazing. The pathology has been incredible. People delaying care. My partners have commented on, diabetic foot infections that normally would be treatable with a small debridement and antibiotics are leading to amputations because people sat at home too long, those kinds of things. And so our big challenge in clinic, and really still an ongoing challenge, is with all of these very sick patients in the hospital, getting them out and getting them adequate follow-up care. People are scared to come into clinic. Even now with procedures in place, they're nervous to come back. And so really upending all of our normal workflows to do video visits through people's cell phones and more telemedicine and those kinds of things. So it really, we've had to be a lot more creative about how we see people and kind of typical timetables for when we'd have people come back to clinic. Those have all been upended, a lot more done by phone and remotely. So in the end, I think some of those things are going to turn out to be real positive. I mean, there are some silver linings to COVID, is that we've had some forced innovation. Stanford, we got a new telemedicine system in the midst of this, which I can't say that's been a fun process, working out all the kinks, but in the end, it's going to be better patient care. And so there have been some silver linings, I think, to come from COVID as well. And Lane, to your question about call for infectious disease. So again, it varies a lot depending on what your specific job is and the size of the group you work within. So I work within a 6-partner group. We rotate hospital call. I take call about 10 days out of every 6 to 8 weeks, but I'm part-time. Call for us is phone calls. I walk around for 7 days straight with my phone glued to my ear. So rarely is it being called. Once in a while, I'll get called after hours, or I'll be woken up at night with a phone call. Our hospitalists are awesome, and they really handle the bulk of the acute issues overnight. And so generally, we work daytime hours in the hospital and we're just answering phone calls. The one thing that I don't know, unique to ID or not, others can comment, but we take a ton of outside phone calls. So we do a lot of curbside phone calls throughout the region. So that's really the bulk of our call responsibility.
Dr. Allard?
Yeah, I'll be brief. I'm definitely not a COVID warrior like some of these people are. And Dr. Miller, I think, may have understated what he's doing right now, because at least at Sanford, the hospitalists are, well, I should go back one step. Our nurses, I think, I've always appreciated nurses, but the ICU nurses are just, they live in those rooms. They're in protective gear all day. And it's really been, I don't know, it's reminded me just how special those people are, and the risk that they're taking right now, especially across the country. It's not just here, obviously. But it's been, from a system standpoint, I found it interesting. So the volumes are huge. Dr. Fenner is seeing 50 people by himself today with no nurse practitioners. We have a census of 50, and I think it might be going higher. So, which is really big. I mean, if you just give 10 minutes per patient and do the math, it's a huge day. So the numbers are huge. Systems have been strained. I definitely think, I'm always curious when I see the hospital capacity numbers. Oh, we're 40% open. I'm like, no, we're not 40% open. We are completely full. They can always make more space, but I think that the nurses, they're really short on nurses. They changed the ratios of staffing a couple of weeks ago at Sanford. So instead of 1 to 3 or 1 to 2 in the ICU, it's now 1 to 3, and the floor has changed as well. So you're seeing the strain a little bit. You're seeing some economic strains, I think, as you have kind of high power surgeons that kind of thrive in the outpatient surgical arena, kind of being forced to slow down or shut down, and they don't do it peacefully all the time. So there's some kind of turf issues, which I think always end up on the side of safety, and it ends up in the right place. But it's been interesting to watch. So yeah, it's been a real challenge for the systems. It's been interesting as someone who's in there, but not actually, not in the COVID unit per se, just to watch what it's doing to our system. It's straining it. I think like the other speaker mentioned, it's going to result in some innovation and some good things too. But it's not over yet. So I think we're all kind of asking, are we at the peak right now, or are we still going higher? And if we go higher, how do we do that? So, but other places have done this too. So.
Other questions?
Hi there. I got a question for everybody. Can you hear me at all? Okay.
Yep.
Hi, my name is Siobhan. I joined a little bit late, so correct me if I'm wrong, but I have two questions dealing with like the whole application process of becoming an internist. So, you apply for residency for internal medicine, and if you want to do a subspecialty, you would do a fellowship of some kind. So part one of my questions is, when you're applying to these fellowships, are they exclusive to internists, or are they open fellowships where you're also fighting against people, who are in that specialty already, just doing whatever fellowship? And then part two of that question, when you are applying for these fellowships, is there something you're supposed to be doing as a resident to like actively boost your resume, or are you just relying more so on like your grades and your scores in your resume from med school when moving forward?
Great question. So I, having not applied for fellowship, I may not be the best answer, but just as someone who helped advise residents, most subspecialties, there is sort of a match process and an interview process, not unlike the residency one in your third year of internal medicine residency. Generally speaking, these subspecialties are exclusive for internal medicine residents. And so like a family medicine resident couldn't apply to be go to cardiology fellowship. That's not true of everything. So like geriatrics would accept from family medicine also, but most of the medical subspecialties are internal medicine focused. And then I would say it's very dependent on the subspecialty that you choose, and maybe even more the program that you're applying to, what kind of things they're looking at. A lot will want you to have done some sort of research during residency and require that, and have sort of some mentorship paths in your subspecialty. as a general rule. And I would say residencies are very much set up to help their residents succeed in applying for fellowship. That makes the residencies look good if people do well as far as fellowship matches, but I'll let other people who have been through that process also chime in.
I mean, I agree with what you said, Dr. Evans. It's very much like the match process that you go through transitioning from medical school to residency. And fellowship programs are looking at a lot of the same things as you're thinking about when you're preparing your med school to residency transition. It's very similar. So, you know, if you want to go to a high-powered research program for fellowship, they're going to want to see that you've done lots of research. If you're going to a primarily clinical program, they may not care so much about how much research you've done. And you have, you know, as you plan for residency, there's always this great debate about whether or not it's good to go to a residency program that has the fellowship that you're interested in. And I think there are definitely pros and cons to that. You know, you can get a great broad general internal medicine program or education at many programs. And sometimes, you know, going to a program that doesn't have that fellowship makes you stand out a little bit. Sometimes going to a place where you can get to know the attendings ahead of time in the fellowship program. I mean, that was my experience. I stayed where I did my residency because I knew everybody. It was comfortable. I didn't have to spend the first 6 months fumbling around, finding my way in a short fellowship. I just got to get right in and be a fellow. And for me, that was really important. So it's not all that different from the transition from med school to residency.
Yeah, and I think a good point is made too about separating a community program from an academic program. Huge, huge difference. Academic programs. I had the benefit of applying to two different fellowships, and cardiology was competitive. The interviews and just the interview process was maybe a little more, I don't know, it felt more stressful. I mean, you'd be there interviewing with 12 other people, and everyone had nice suits on, and some of them seemed accomplished. Some people that were actually cardiologists in foreign countries before they came here, so they knew how to do it already, which was a bit intimidating as someone right out of internal medicine residency. Academic programs absolutely want a research pedigree. So that's, if you want to go to the Mayo Clinic, you need not apply without a research background. I mean, it's an academic place, and that's what they want to see. Personality matters. So your interview strength, I think, matters. It also matters if you have powerful recommendations. So if you train with people that are either well-known or just known to the people you're interviewing with, that matters as well. So I think Chester it was, but it was a more relaxed process. It felt friendlier. I felt like I was amongst my people, which was nice. But you know, it's something where if you exactly know what you want to be, it's never too early to start. And research doesn't have to be research. You can just get your name on a lot of papers. So if I was, say, I wanted to be a GI fellow, and I was pretty sure that's what I wanted to do, which I wouldn't. But if you wanted to do that, you'd probably be wise to do an early rotation in GI. Figure out somebody that you like that, you know, might be of some stature or profile, especially someone that likes to publish, and then basically you offer yourself to them if you have any free time. Say, if you want to, you know, like, I'll be happy to do research for you. I'd like to publish papers with you. You know, assign me work. I'm here to serve, and that could go a long ways. Just having your name on 4 or 5 papers with a well-known person would probably be a good shoe-in. Other things, you know, I put infectious disease, endocrine, rheumatology are a little bit more relaxed, and it's probably not as important to you know, break yourself during your internal medicine residency. Focus on getting good board scores. You know, it's, you know, there'll be a program for you if you want one. So that's what I would say.
I haven't worked with a lot of,
Oh, sorry, go ahead, Nate.
I was going to say, I haven't worked with a lot of residents, and there are certain, as everyone alluded to, there are certain specialties that are more competitive than others, just the way it is, and those always change. Those ones are more than likely almost require research prior to matching. And you don't necessarily have to go to a residency that has those programs. We've matched residents in GI. Obviously, there's a cardiology fellowship program in Sioux Falls, CARDS, HEMONC, critical care in the last few years. But the key is you have to be driven, and you're selling yourself when you go to those programs. Similar to previously, if you were able to do a sub-I pre-COVID, at a local facility. That was at a facility, that was your interview. It's the same way for fellowships as well.
I saw we got Dr. Balloon joined us. Thanks, Dr. Balloon.
Sorry, I'm late for the game. I had kids' conferences. I apologize.
That's okay. It happens.
Well,
So
I did want to
early
chime in with Dr. Allard. I think everybody wants to be a GI fellow, Dr. Allard. I am pretty sure that's true.
I'm just gonna laugh.
Students, Dr. Balloon, early on, we each talked about our training path, and then just sort of what your day-to-day balance is like, what your sort of clinical practice looks like in gastroenterology.
Absolutely. And thank you guys for allowing me to be here. I'm so sorry I'm late for the game. So one thing that I remember very specifically with Dr. Maria Bell, who is one of our gyn-oncs here, and she's amazing, told us during our 3rd and 4th year that when you train here at the University of South Dakota as a medical student, and certainly during residency programs, you are good enough to go anywhere. And I took that to heart because I felt I had great mentors. I felt I had wonderful teachers, and I learned just a ton being here in medical school. I did go to the University of Minnesota for both my residency, and then I actually did a break year, and I was actually a hospitalist for a year, and then went back for my fellowship. GI is a little different, so I think you alluded to a little bit. There's some competitiveness to the GI field, and I think you guys all had wonderful points. You know, Nate and everybody who's been talking, is that there are some more competitive fields, and getting in a little bit early with some of those fields, I think, is a very good idea. Basically, we can't do sub-Is right now, but I went to the University of Minnesota, did GI fellowship, or did GI rotation when I was the first part of my 4th year of medical school, and got in with a gentleman by the name of Dr. Lake, who's a mentor of mine, and really followed that path and did my fellowship at the University of Minnesota. I really love GI for a number of reasons. One, I love to use my hands, and I really love to use my brain for the diseases that I get to see and treat every day. There's complicated diseases in all of our fields, and there's good and bad diseases in terms of how we treat them and what we can treat in all of our fields. But my life is sweet, guys. GI is an awesome life. I get to do procedures. I get to help people. I get to see really, really, really great patients. And the reality is, when I go to work every day, I get to go help somebody. And when I come home at the end of the day, I hope I get to feel that I helped somebody. And I think all of these different fields in internal medicine, whether you're an internist, whether you're a hospitalist, whether you do ID or rheumatology or whatever, that's kind of the beautiful thing about internal medicine, is that we all get to help people in a variety of different ways. And it's super, super rewarding.
I think a theme that a couple people have stated, and I would really echo, is the importance of mentorship. And that's true as a medical student. That's true when you're a resident. You know, I think at some point in your training, you sort of see 1 or 2 physicians, and it's probably the specialty that you end up choosing. And you say, that is the type of doctor that I would like to be. And, you know, be upfront and talk to those people. Make them part of your circle. And I think that you're just going to be better off finding your path if you have someone like that in your corner too.
I absolutely agree with that. I think that's an excellent point. I remember the 2 people that I had when I was at the end of my 3rd year, beginning of my 4th year of medical school, Dr. Barker and Dr. Ridgway, and those are the reasons that I went into GI. I loved it. I absolutely loved it. I hit internal medicine at the end of my 3rd year, and I was actually going to be an OBGYN after my first rotation, my 3rd year, and hit internal medicine. Absolutely fell in love. Loved the idea of GI after I met with Dr. Barker and Dr. Ridgway. And like you said, Kelly, having those mentors and having those people write letters for me, and those people, you know, stand up for me. And we're all happy to do that with all you guys. Once we get to, you know, have the opportunity to have you with us, makes a huge difference in your career path and your trajectory. It really does.
Yeah, and I might add just one comment is, again, the guy that picked the wrong specialty. You know, I think me going into cardiology first was probably the product of like medical school is an achievement pathway. So you're a good high school student, you're probably in the top 5% of your class. You're a top 5% college student. You get to med school and you're AOA or whatever, you're working hard. And I think it's hard sometimes to step back. Residency is a time to step back and say, what do I really want to be? So for me, I think part of the reason I chose cardiology is because I could, and I knew it paid well. There was a big financial reward for it. I maybe didn't think as much about what the job was or if it fit me. And I had to actually go experience it and realize wow, I'm not a proceduralist. I don't think this is what I want to do. So I would maybe just a cautionary tale for me, just kind of step back. You don't have to get it right on the first try. And I actually think I was better for having taken a wrong turn, but it's a chance to step back. You've been driving hard since you were in elementary school, and the decision you make in your internal medicine residency or before, and if you're in medical school, will set your whole life's work. And if you don't like it, I don't care how much you're getting paid. Unless you're really driven by money only, it won't be sustaining. You won't be happy. So you really need to read yourself. What is going to make you happy in a job? To the extent, there's a lot more to life than your job too. So maybe you're just a happy person and you'll do whatever. Then maybe you're looking at lifestyle. I'm a happy person, I just don't want to work my life away. Well, then you better pick a job that has a nice lifestyle attached to it, or find a job within a specialty. Even what I think of a fairly malignant lifestyle, like a general surgical practice. I'm sure there's someone that does nocturnist general surgery where they work only a shift, and it's probably not that bad. So, but do search your feelings, because this is probably a good time not just to drive hard and get the most competitive and highest paying thing you can, unless that's the thing you really want to be. So.
Yeah, fair point.
I was going to second that. That's exactly what I was thinking, is we do talk a lot about salary and call schedules and lifestyle, but I would just encourage you to maybe set those aside a little bit, because no matter what field you go into, there's going to be flexibility in those things. You can tailor your job and your practice to what you want about those other things. But if you go to work every day and you really don't enjoy the patient population you're seeing or the job you're doing, it's going to be a drag, even if it's a 9 to 4 p.m. job with a high paying salary. So, that was one thing that I had mentors early on that really kind of pointed that out to me. ID is one of the lowest paying internal medicine specialties. So, for me, that wasn't on the radar because, well, one, we're all doctors. So you're going to support yourself just fine, regardless of what you do. And for me, it was really important to just have something that I wanted to go to work to do every day that I found intellectually stimulating. And so when I found mentors that were super passionate about their jobs, and they just knew an incredible amount, they had all this clinical experience, I think that was when I found my fit. I was like, oh, these are my people. This is what I want to do. And then to me, the other stuff mattered less, because that could all be tailored to what I needed.
To follow up on Dr. Shu's comments and Dr. Allard's, I completely agree. Go into what you're passionate about, because if you're passionate about what you do, the good days will be great and the bad days won't be so bad. And you'll have that in no matter what field you go into, whether it's internal medicine or another specialty. And the other thing, don't let someone tell you that the field that you're going into isn't a good field to go into, because you know what you're passionate about, whether it's internal medicine, OB-GYN. Hopefully all of you are passionate about internal medicine. I'm sure that's why you're all signed on today. But just make sure you enjoy it, because at the end of the day, there's going to be good and bad in all the specialties. None of them are easy. And as Dr. Shu said, we'll all get by just fine, no matter which field we pick.
Any other student questions?
I have a question. Hi, I'm San. I'm a second-year medical student. So I don't really know much about the process, but in terms of away rotations, I know this year is really weird with COVID-19, but is it fairly common for people interested in IM to do away rotations? And if that's the case, do we have the opportunity to work in a subspecialty that we're interested in while we're at the away rotation, or is it more for just general IM?
I think you're going to hear mixed reviews about this, and it probably depends a little bit about experience and about where you are. I never did an away rotation knowing that I wanted to do internal medicine, and I don't think in internal medicine that's probably not a necessary thing to do. There are some specialties where you will get advice that it is absolutely necessary in certain surgical subspecialties, for example. As a chief, I recall my program director at the University of Colorado, actually, her take on doing externships in internal medicine was like, it can hurt you and it isn't necessarily going to help you. Like, you really would have to shine for it to be a big plug as far as your residency application to that program. And certainly if you go and you struggle a little bit, then it does hurt your residency application. So I would say compared to other specialties, not necessary. I think for you as a student and trying to decide really where you want to go to residency, it could be very helpful because you will get much more of a feel of the culture program and the clinical sites, et cetera. But not necessary in internal medicine compared to some other specialties per se. But you can do, a lot of people, you know, it might be hard to get a general internal medicine externship and easier to get a subspecialty elective externship. So I know a lot of students who have done that. Someone's probably going to disagree with me on that.
I think that's true. I don't think for internal medicine you're obligated unless you are dead set on a specific program or a specific geography. You know, internal medicine isn't as competitive as other specialties, and so I don't think you're compelled to. And I would second what Dr. Evans said. It's going to be hard to get a sub-internship or a general internal medicine experience because other facilities are trying to get their own learners through those opportunities. And so more often than not, if you're going to do an away rotation in Pillar 3, you're probably going to be doing a subspecialty rotation. So if you choose to do it, make it one that you think you're interested in, that you want it from a career exploration standpoint.
I'm not going to disagree with either of you, but.
Oh, I'm sorry.
Oh, go ahead, Brett.
No, Nate, go ahead, buddy, go ahead.
Oh, I was going to say, and definitely I agree with what Dr. Hsu and Dr. Evans said. From my standpoint, I knew I wanted to stay in Sioux Falls. I did not do an externship. So if there's an instance such as that, I would encourage you to do an externship, because that's probably my biggest regret is I haven't really seen medicine outside the area of Sioux Falls. So there is that benefit too. But other than that, I completely agree. From interviewing residents and med students from multiple different areas, you don't have to do a sub internship outside of your.
And I absolutely agree with all you guys. My only circumstance was a little different. Knowing that I wanted to go into a competitive field, Stan, I knew that I wanted to be in the Midwest. My wife's from Minnesota, and so the University of Minnesota was going to be top of my list. So going into what I want to do in a competitive field, what it allowed me to do, I did not do a sub-I. I did an elective in GI for I think 6 weeks, something like that. And that really got my foot in the door with some really great people at the program that I thought I wanted to be at. Then of course, people, not the whole program. But when I got through the interview process there, I knew that that's the place I really wanted to be. So it got my foot in the door. I tried not to be an idiot, right? I just tried to be a really good student and learn as much as I can. And hey, I'll go take this consult and I'll do everything I can to impress you guys. And that's what we all try to do. Like you guys all said, we've all worked very hard, since Dr. Aller said, since middle school. That helped me tremendously because I met my mentor, Dr. Lake, who literally helped me get into my fellowship program afterward. You know, this is probably a 1 in a million shot kind of a pipe dream thing. But for me, it allowed me to get to the people that I needed to meet and get the experience that I needed to get at a place that I wanted to be at in an elective thing. Now, absolutely all my friends and colleagues are 100% correct. You don't need a sub-I to go to a great place and get a great training and still launch your career however you want to do it. But it's a great question.
Yeah, I'll be brief. I don't think I have much to add, except maybe there's a reverse angle to this too, where you're almost exploring the program rather than trying to show yourself. Because I think as a medical student, it's unlikely you're going to make such a splash that they'll ever remember you for a fellowship program. But maybe you have a grandma that lives in Scottsdale and they have a program that you might want to go to someday, but you're not sure if it's the right fit or if it's strong enough for you. It might be a chance to go and just interview a place that might make sense. Like, can I live with my grandma? Can I, if there maybe there's some reason logistically why you should look at this place, you don't know enough about the program. So it might be a good exploration for you to go away. But I think it's unlikely you'd go there and take an academic center by storm as a second-year medical student, and they would never forget you and would have to have you back. I think I'd look at it more as you exploring them, and is this a place I really want to be? But I think it can make sense. It could be fun to go south too in the winter.
We can take another question or two if anyone's got one.
All right, my name is Jackson Shriver. I'm a third-year med student. We've talked a lot about fellowships, but I was curious if any of you had specific things that stood out about why you chose to go to the residency that you went to for internal medicine, or things that you look back on upon your program that you think really stood out and were something that like future students should look for as well.
Great question, Jackson. So I think how everybody chooses how to rank their residency programs is very individual, and it's going to depend on a lot of factors. One nice thing about internal medicine is, in my experience, I think coming from this university for medical school, you really do have the world at your fingertips. So you should apply to whatever programs you think you want to apply to, because you've got a great chance of matching anywhere, big academic programs across the country. I think, and it's okay if when you go to your residency interviews, it's okay if you don't know exactly what your final career is going to be. That's perfectly fine. And that's another great thing about internal medicine. I think my decision-making process, I kind of chose larger academic centers. I think when I applied for residency, you got your first 10 for the same price. And so I applied to 10 and no more than that. And I chose locations that were attractive to me. I was engaged at the time, so it mattered what my spouse thought too. And I ranked the University of Colorado at the top, partly because of location and people that we knew there, and partly because of the program, their primary care track and a larger academic multi-site program. I think I really didn't know what I was looking for in a program until I started interviewing, and really sort of got the feel for how places were different and what things the residents there found important and stuff like that. So I didn't have all the answers before I started actually doing that. I think it's going to be challenging for those of you who have to interview via Zoom and not be on site. You might have to do a little more legwork than I did in advance of my interviews to get to the bottom of those answers this year, but I'm sure programs are really also working very hard to make sure that they get that feel and that information to you as best they can.
Just to add on that, Jackson, I felt of all the places, and I was kind of like, Dr. Evans too, I interviewed kind of as select places because it was cheaper. And I had no money, but I also knew I want to stay in the Midwest. But for me, and this is gonna be the tough part, and I know you're a third year, so hopefully by the time you are going through this process next year in terms of interviews, for me, the biggest thing was the resident dinners. And I don't know how y'all else feel. I just got the vibe, or I didn't get the vibe about the program by sitting down with 10, 15. Listen, if 3 residents showed up, I knew this was not the program for me. If 20 residents showed up and talked, just how great their program was, and you could see the collegiality, because you're going to meet with program directors, you're going to meet with a bunch of people who are going to interview you, but really those interns, if they don't look mad and the residents are all happy and happy to be teaching those interns, that to me was the best barometer test that I could ever give. I don't know how else you guys feel, but for me, that was it.
Yeah, and I might add, they're definitely not all the same either. I was in Minneapolis and there were 3 programs there and they were really distinct from each other. And I don't, I'm old, but I don't think this has really changed that much. So I trained at Abbott Northwestern, which has a reputation as being, you know, sort of it's a Minneapolis hospital, you know, all the specialists are there, but it's not it's an affiliate of the university, but it's not a university program. So it's like a community hospital, kind of like Sanford or Avera. But it had a reputation for having really intensive, like intensive staff resident collegiality and like mentoring. And that was sort of the reputation. They kind of got like a lot of our top students, I guess, like a lot of the AOA students from med school would go there, but it wasn't like people that were necessarily going into specialties and that sort of thing. And they had a reputation for, this was way back in the day, they didn't have any duty hour restrictions at some of the places. And so I think Abbott was really early in that, kind of realizing like, hey, we don't have to crush people's souls to train them. And that was a well-advertised fact too. So I think that influenced me. Whereas Hennepin County Medical Center, which was like a mile away, was kind of the opposite. And I had deep respect for it because this is a place where you're going to go and you're going to get crushed. And they'll tell you that. You know, I remember talking to friends that did residency there who said, I did 4 chest tubes in my first week of my intern year. I'm like, I think I did 2 my entire residency. You know, because you're in a trauma center, you're in the middle of the night, you might be the only licensed doctor available for a room. Like the other people there, but your attendings might not be there. They kind of let the residents run the place, and they're doing some gnarly stuff. In the end, I think that's good training of sorts. Like you come out of there battle tested. It's almost like going to war, and you learn how to do things, and it forces you to, you know, mentor with older residents. And there's some good things about that. I think I found that a little intimidating. The University of Minnesota was the third program, a very traditional university program, very hierarchical, specialty everything, good training, great sub rotations. Probably not a real high profile for the internal medicine residents because you're sort of a peon wherever you go. But so I think the programs definitely are all different, and that temperament is something you probably do have to watch out for. You know, do you want to go to a program where you do a lot of procedures and kind of run the show at a tough community hospital? I think good things come of that. Are you academically minded, want to hang out with people that write books? You know, that's a different thing, or a solid community program. So yeah, they're very different.
You might think about too what patient population you want to take care of, because that's going to heavily influence where you go as well if you have specifics in mind. For me, one of the things, now I can't speak to the match. I did a couples match, so there was a lot of negotiation that happened with that. So we basically narrowed it down to 4 programs that we both liked and said any of those 4 are fine. But for me, one thing that was really important was having a VA. I loved my VA experience as a student, and for me, training at a VA was really important. And I would say that is some of my, hands down, my best training when I was a resident and a fellow. And so think about things like that too. What kind of community you're looking for? Is there a specific demographic? Do you really want to take care of a minority population, an underserved population? Think about those things too, because that will influence where you apply and look.
I love that you said that, because that actually totally affected my match list too, was that I at a certain point, I felt like I just can't go somewhere where I'm not training at a VA. I loved that place too much as a medical student.
Yeah.
I agree. I love the VA. I did my chief year at the VA in Minneapolis. I love the VA experience here in Sioux Falls. There is no greater appreciative patient population than the veterans. And I'm happy that I still get to take care of some of them here. As I know all my friends and colleagues do. And yeah, so you know what, Dr. your point is absolutely spectacular, and all the rest of you too. That patient population, that, you know, that community base versus, you know, the some of the poorer based populations, you're going to find all sorts of programs that will serve those needs for sure.
We'd take one more question if anyone's got one.
This is a pretty specific question. Hi there, my name is Sarah. I'm a 3rd-year medical student. Dr. Miller, you mentioned that sometimes hospitalists will serve as intensivists at certain hospitals. Could you tell us what the proportion of intensivists are that are hospitalists versus like pulmonary critical care?
Nate, you're muted.
Thank you. So, we don't work as intensivists at Avera. We work hand in hand with the intensivists in the ICU. The vast majority, so if you're at a larger tertiary care facility similar to Sanford and Avera, The majority of time it's staffed by either home critical care or critical care. Hospitalists across the nation, about 60% of hospitalists will do critical care. For example, Aberdeen has a hospitalist program. They have a 4 to 5 bed ICU. They do the critical care there. That being said, things could change, but it depends on where, similar to everyone else, it depends on where you want to work. Is it at a tertiary care center? Is it at a hospital size of Aberdeen or Brookings? And what level of ICU critical care would you like to provide? In addition, there's other avenues to go down critical care. For internal medicine, there's a multitude. You could go on and do pulm critical care, which is 3 years. You could do critical care, which is 2 years, ID critical care, cards critical care. And so there's multiple different ways you could do it.
Thank you.
And it's very site specific. So if you start, if you're interviewing for residency, for example, that's an intelligent question to ask about the hospitals that you work at. And you'll hear the term closed ICU, which would mean the only people caring for patients or the primary teams caring for those patients are headed by usually a pulm critical care attending and fellow and resident team usually, versus an open ICU in which the pulm critical care specialists are usually serving in more of a consulting role, and the hospitalist is still the primary, or there's sort of a team dynamic to that.
I will add one thing that I think hopefully all my friends and colleagues will agree with, that when you go through an internal medicine program, you will come out being able to deliver spectacular critical care capabilities. And that's just the nature of the training that we've all gone through, and that if you guys are all interested and want to do this, that you will come out knowing how to manage vents, knowing how to manage critically sick people, bone marrow transplants. That's the beauty of internal medicine, is you're going to get this wide swath of knowledge and detailed knowledge base for all these things. I mean, I'm a GI doctor. I'm a simple scope jockey sometimes, right? But at the same point, I've taken care of a lot of critically care patients in the last 8 years of my practice here, with all my friends and colleagues here. So like, it is the knowledge that I gained throughout my residency allowed me to do what I'm doing today. And it's just spectacular to think back on what we're all trained to do and can still do, because we had just such wonderful in-depth training.
Yeah, that's a great point. I remember coming in as an intern and just, hearing about the Denver Health ICU rotation and feeling like, how am I ever going to get to a point where I'm the only person in a huge catchment ICU in the middle of the night? No way. But the sort of slope of your skill increase over those 3 years of residency is profound. And internal medicine is awesome because you learn how to take care of a really wide variety of very sick people compared to a lot of other specialties. And even if you end up not doing that, I feel comfortable that, when I have a sick COVID patient coming into the Brookings Hospital now, I've done that before, at least, whereas my family medicine colleagues probably have not taken care of patients that sick, at least not very often. So any last questions or any just last comments from our panel?
It's a great field, internal medicine. I love what I do, and I know everyone on this phone call do as well. And you have a lot of opportunities to stay general or subspecialize further. I have no regrets going into it.
Yeah, and definitely the world needs you. Like, Dr. Evans is out there doing a job that she could point to a map and go wherever she wants. That internal medicine outpatient is in demand. Hospitalists are in demand. So whatever path you pick, there'll be not only a job waiting for you, but like you'll have your pick of jobs, which is, I guess, true in most specialties, but it's more true of internal medicine, general internal medicine, specialty internal medicine. It's a nice thing to not have job insecurity when you leave your 3-year residency.
And sign up for ACP, everybody, even if you think you're going to go into OBGYN. I went into pathology, and here I sit. So you never know. And there'll be something there for you no matter where your interest lies right now.
I have to
Yeah,
ask Dr. if did you actually play the harp?
I was just
that-
gonna ask you-
yeah.
I was just gonna ask you to play.
I just had it brought in for this meeting, actually. So I could seem sophisticated.
It looks fitting for you, Eric.
Yeah.
He actually sings. Well, you do actually sing, but
Yeah, not tonight, though.
I'd like to thank all of our speakers tonight for taking time out of their very stressful, busy lives to be here with our students and answer questions. And I'm executive director of the chapter. If you have any questions, please reach out to me. My email's on the South Dakota ACP website. And I look forward to maybe seeing you in Deadwood in 2021. Our meeting will be there, hopefully. So thank you again, everybody, and for taking care of our families. So.
And I would say we're here because we feel passionate about our careers. And so if as students, if you have questions or are looking for mentorship or help at any point of that decision-making process, I think we're all open to trying to help you with that. So email us, contact us.
Absolutely.
But thanks for
Thank you
joining.
all for being here. I mean, honestly, and thank you guys for hosting this. I am so delighted to be part of it. Again, sorry for the late joining, but listen, I'm always happy to have students with me. You know, that's how I got into this, and I love it. If you guys want to play with the scope, to just be with me and learn about it, just please join us. We're happy to have you all of us.
Great. Thanks, everybody. Have a great night.
Thanks. Good night.
Good night. Bye.
Thanks, y'all.